So as folks are making their way down, I wanted to ask tonight that you join me in a moment of silence for Christine Gallery. She was our beloved Senior Vice President for Planning and our Chief Strategy Officer. She lost her 20-year battle with cancer this past weekend. We're actually all heartbroken about it. For the past 25 years at Emerson, her sheer brilliance has helped Emerson to grow and emerge as one of the leading community hospitals in Massachusetts. Among her many, many other achievements, she was responsible for our comprehensive breast health center accreditation with Dr. Lisa Ragulin-Coyne, and she has helped us achieve many mother-baby quality awards, a national SHSMD, which is a strategic society at the national level, an award for that. And she was a driving force behind tonight's event. She played a large role in recruiting many of the outstanding physicians that are here with us tonight. And I know, knowing Christine so well, that she is here with us in spirit. So please join me in just a moment of silence on behalf of our beloved Christine. Thank you. So it is so great to see so many friends here tonight, and it's nice having all the girls here, right? So, finally a night where we can really talk shop and talk about the things that are on our mind. As moms, as sisters, as wives, just as women in today's society, given the hectic pace and also what's come out of the COVID-19 pandemic, where many of us were isolated for days and days and weeks and months, one of the things that we often don't do is take care of ourselves, right? How many in this room, raise your hand, puts everyone else before themselves when it comes to your health? I don't think there's one person that doesn't do that. So what I can say before we get going is we have some amazing sponsors tonight that are all very vested in women's care at Emerson, and I'd just like to thank them. Concord OBGYN, Sharon Mendoza team at Compass Realty, Underskin Skincare, and Wico Hospitality, which nurtures us from the inside out. Their generous sponsorship has underwritten tonight's event and allowed the ticket purchases and donations to go directly where we want them to go, supporting women's health initiatives at Emerson. But as you know, many of the events don't really get done without the help of our amazing volunteers, and Emerson has volunteers like I've never seen anywhere. So please join me I'm going to ask them to stand in thanking Liza Carey, Chessie Cataldo, Tanya Koch, Julie Kahn, Betty Ann Killian, Amy Leahy, Molly McLeod, Michelle Mercier, Adrienne Principe, Trish Seifer, Deb Van Walson, and our own Boston Globe parenting reporter, Kara Baskin. Thank you, ladies. You really are going to make this a night to remember. Often women play the caregiving role, the role of a spouse, taking care of parents, taking care of friends, and they ignore their own health needs. We hope that our discussion tonight with these outstanding clinicians, many of whom are listed in the Boston Magazine 2024 Top Docs list that will be coming out in February, will remind us of the importance of keeping our health a top priority. And I like to think of it as the airlines, right? When the oxygen mask comes down, you've got to put it on yourself before you can take care of everyone else in your life. So if there's one little word of wisdom you take, put your oxygen mask on, and that can mean a number of things. Make a PCP appointment. Your back's hurting you, go to the physiatrist. You need that, down below visit, go get one of those. Your knee hurts, go to the orthopedic surgeon. Whatever it is that ails you, need a little buff and puff up and, getting those things moving, you're going to go see Dr. Englazier. There's lots of things. Oh, and the dribbles. We've got someone for that, too. Dr. Onika Williams, who's, known for making sure you don't have to use pads anymore. So listen, in this room tonight, what's said here stays here. It's like being in Vegas, only better. And you can talk privately afterwards. The docs will make themselves available, or ask questions, because most of the time, what's on your mind is on everybody else's mind. So it's my pleasure now to turn the program over to our moderator tonight, Dr. Michelle Dallencourt. She's a family medicine physician that you might have met at one of our urgent care centers. I know I've seen her with my daughter, and she was amazing. She earned her undergraduate degree in biochem and molecular biology at UMass Amherst and her medical degree at UMass Medical School. Completed her residency at Montefiore Medical Center in New York. She also earned a master's in health policy and management at the University of California in Los Angeles as a Robert Wood Johnson Clinical Scholar. She serves as the medical director of Emerson's Urgent Care Center. She lives in Lancaster with her husband and 2 boys. And so, Dr. Dallencourt, the show is yours.
All right, good evening, everyone. Welcome to a night that's all about celebrating the strength, resilience, and well-being of women everywhere. It's a privilege to be here this evening to moderate this distinguished panel of women. We have an incredibly insightful discussion ahead, covering many important health topics. I want you to take a minute and imagine a world where women's health takes center stage, where knowledge is power, and where the night is alive with wisdom and empowerment. Well, that world is here tonight. Our panel of physician women represents the very heartbeat of women's health. They are the ones who've dedicated their lives to ensuring that women's health isn't just a topic, but a movement. And trust me, tonight we're not just discussing it, we're celebrating it. So let's dive into an evening of insights, inspirations, and most importantly, empowerment. It's time to put the spotlight on women's health, and it starts right here, right now, with this remarkable panel. Before we delve into our conversation, let me remind you that your participation is essential. We'll have time for questions later, so please feel free to share your thoughts or pose questions when the time comes. So let's get started, and I encourage you to join us on this enlightening journey. Our first panelist of the evening is Dr. Christina Thomas. Dr. Christina Thomas has been a practicing OBGYN for over 16 years. She joined Concord OBGYN in Emerson Hospital in 2012. She attended the University of Buffalo School of Medicine and did her residency at Tufts Medical Center. In addition to practicing OBGYN, she also enjoys seeing patients for Botox appointments. Dr. Thomas lives in Carlisle with her husband and 3 children. She enjoys reading, hiking, and relaxing with her Yorkie, Cece. Dr. Williams.
Oh my gosh, hi. Everyone was asking, are you ready? Are you ready? I'm like, I don't know. And then everyone walks in, I'm like, oh my gosh, there's a lot of people here. All right, so I'm trying to advance the slide. Okay, there we go. So I am going to talk about perimenopause and the menopause transition. So I am no expert, but I am currently where most of you guys are in my mid-40s and experiencing a lot of symptoms that I don't really enjoy. But you're not alone, and there are definitely certainly treatments. So next slide, there we go. The average age of menopause is about 51, 52. Now, some women can be in their 40s, some women actually in their 30s, some women in their later 50s. It's defined as no period for about 1 year, and you may be experiencing many different symptoms even before that last period. And the symptom range is extraordinary and very different for every single different woman. And it can vary between race, BMI, any other medical comorbidities that you may have. Next slide. So I kind of like this picture because it kind of hits all the different spots. And we are gonna focus on just a couple because I only have 10 minutes, but know that any of your symptoms can be related to the perimenopause and menopause. And I don't want you to say, oh, it is just menopause and ignore them, but definitely talk to your GYN or talk to your PCP and make sure there isn't anything else that could be going on that we're not missing and we're just brushing it off like, oh yeah, I'm at that age. I'm gonna talk about two different topics that one in particular is one that not many women bring up, but it is a real issue and real thing. So let's delve into it. Next slide, please. Weight gain. Okay. So we know we have children, some of us, and there's definitely changes in pregnancy, and you deliver and you want yourself back in more ways than one. Children are lovely. I love mine to death. But it takes work, right? And it takes work because you don't have that time for yourself. You can't go to the gym for an hour or take a nap and go get your facial and your massage and work on yourself. As Chris pointed out, we have to put our oxygen masks on first. So it is inevitable because of life, maybe stress, and maybe other medical problems that may come up as we age, that you may start to gain weight. And in menopause or the perimenopause, it's that central adiposity, right? It's like everyone comes in and say, what's this? What's going on here? I'm like, I know. So easy fix, and not easy, but get out there, get your steps in. It's really important. I listened to some podcasts the other day, and it was like, just start off with 8,000 steps. And you'd be surprised going up and down your stairs, doing laundry, going to the market, anything. Try to get your steps in and then work from there. And then there's always diet. And I'm not saying Weight Watchers or macro counting, but there's so many things out there. You have to find one that works for yourself. But it does take a little bit of work, and it might take even more work as we enter our 40s, and then our later 40s, and then when we enter menopause. We then, again, will look at walking strength training, and then we have hormone replacement therapy. And so I'm not going to get into a lot of the treatments of hormone replacement therapy. It's a whole separate topic and one in itself. But it can help preserve some lean body mass. It can help prevent some of that visceral adiposity that women tend to gain right in the midsection. So I'm not saying hormone replacement therapy is a weight loss medicine, because it's not, but it can help a little bit. It can also help your sleep. And when you have more sleep, you have more energy, you feel better, you're happier with your life, you have a little bit more time, hopefully, for yourself, because you're not taking a nap because you actually got a good night's sleep. And maybe you only woke up once to go to the bathroom, maybe once to throw off the covers, not every hour. You're going back and forth, turning on the fan, opening the window, your husband gets up, all that stuff. So again, there's different treatments. So it's definitely a really hard one to talk about, and one that, again, you'll need to work at, but certainly bring it up with your provider. We're here to help. And I know Dr. Doyen is here today, but there's also newer weight loss medicines. I don't myself prescribe those, but they're supposed to be revolutionary and something to talk to your primary about. Next slide. Okay, here's the big one. Save this one for the last because no one wants to talk about it. And it's a real issue that a lot of my patients hopefully do feel comfortable bringing it up with me. There's a really large internet presence about libido and magic drugs and do this and do that. And there is some treatment. So there is a loss of libido. It starts to actually decrease beginning in the mid-30s, kind of when our fertility starts to decrease. And about 50% of women have a neutral effect or a neutral presence with sexuality or sexual interest in their 50s. And so it's only a problem if you are bothered by it as a woman with your partner. And their studies have really only looked at heterosexual couples. And so there's not a huge amount of research dedicated to libido and what we call hypoactive sexual desire disorder, where you just don't want it. And that could be because of a bunch of things. One, it could be because it hurts. and I'm going to say the V word, your vagina is in pain, okay? It's a real thing. And it is because your hormone levels start to decrease. And when you're in menopause, your estrogen, progesterone, and your testosterone levels are very low. And so if it hurts, you're not going to want to do it. And you have less lubrication. Maybe you can't get aroused as much as before. So definitely talk with your physician about that. I know Dr. Williams will probably speak about pelvic floor PT, but there's certain reasons, and I know we have a few of our pelvic floor therapists here, but certainly pelvic floor PT will help. There's vaginal estrogen that I think most or all women postmenopausal, if they can, should use, which will absolutely help that. So I put GSM there, and that is the proper term for atrophic vaginitis or a painful vagina or very dry vagina. And they changed it because saying vagina is taboo, apparently, in the United States. Even though we all have, and Chris, you actually said it too, it's like the down there. No, like, be proud of your vagina, all right? But definitely, like, seek help. Like, there's help. So pelvic floor PT, vaginal estrogen, and also, I don't want to brush over, but like psychotherapy, there's sex therapy, and also sex tools, or toys, but we're supposed to say tools. So get a vibrator, okay? Like, use it. And I promise, and I want you to feel comfortable bringing it up to your gynecologist or your primary care, because it's a real issue. And why should men have all the fun in their 50s? And they have a little blue pill. The other problem is those medicines are actually very costly. Like the vaginal estrogen products are really expensive, which is really frustrating for us as prescribers. And so we're trying to work with, hopefully, the drug companies. And there is also a couple other treatments that aren't prescribed very often. One is an injection for desire. It's called Vyleesi, of course. We have to shoot ourselves with a shot before we think we might have relations with our partner. There is that. And we have a little pink pill. However, you can't really drink alcohol with it. So, again, talk to your provider. It could be for you. But we're here to help. And please ask. I want you guys to ask, because you're not alone. Next slide. I think that's all I have for you guys. But yes, there's obviously talk to your OBGYN, your PCP. Good information. The North American Menopause Society has great handouts for patients and great information, because not everything you read on Google is correct. It's okay. And then the Mayo Clinic also has some great information. That's all I got. Thanks for coming out tonight, guys.
Thank you, Dr. Thomas. All right, so now we have Dr. Raghulan Coyne. So Dr. Coyne completed her undergraduate. We're gonna go to Onika. You're an urgent care, you got this. I know. No pressure. Hold on. All right. Dr. Onika Williams. So, Dr. Onika Williams is an award-winning author and board-certified urologic surgeon at Emerson Urology in Concord, Mass., and assistant clinical professor of urology at Tufts Medical School. She received her bachelor's in biophysics at Johns Hopkins University, her medical degree from Harvard Medical School, and her MPH from Harvard School of Public Health. Dr. Williams completed her general surgical and urologics training at Massachusetts General Hospital and Leahy Clinic. Her practice philosophy is one that embraces holistic health and the power of a positive mindset. She specializes in female and general urology. Please help me welcome Dr. Onika Williams.
Thank you, Michelle. Let me just make sure I have this. Okay, well, good evening, everyone. Good evening, everyone. So I'm not going to stand behind the podium because you can tell that I'm vertically challenged, and I actually still stand on a stool in the operating room. So if I stand behind the podium, I almost disappear, and I kind of like to move around a little bit. So I'm going to stand here and have some movement. This is incredible. Thank you to the organizers for putting this together. I think it's really, really important for us to have this opportunity to have open conversations about these issues that many women feel shame about and never talk to anyone about. And then if you're in a situation where you're able to have some conversations, you realize that everyone is dealing with some semblance of these issues. And certainly if you're within a certain age range, then these become part of your reality. And so I'm going to speak. I thank I don't know if I can do the stand-up act, Dr. Thomas. Very well done. But certainly there's a lot of overlap between urology and the GYN. And as we deal with the lower and the genitourinary tract, this is something that I encounter day in and day out. And it does feel like the elephant in the room, because many of you will come with these complaints and be completely surprised that this is a part of your hormonal changes. And so what I want to do, I think the three things that I want to leave you with today is, one, that we actually understand what is going on, and we can help you to understand it. Number two, we can do something about it. And then number three, come see us and let us help you. Go back, please. I wanted to talk about the things that I see most commonly in my urologic practice: urgency and frequency, recurrent urinary tract infections, urinary incontinence, and microscopic hematuria, which is blood in the urine. And you might ask yourself the question, well, what do these things have in common? How are they related? Next slide. They're related because they are a part of what you would have heard Dr. Thomas mention briefly, this genitourinary syndrome of menopause, which is a new name for what used to be coined atrophic vaginitis, vulvovaginitis, which essentially means thinning of the vaginal structures, the vaginal lining. But what we recognize is that there are many more components to the lower urinary tract than just the kind of vagina and the vulva. And they were involved the bladder, the urethra, sexual function. And so this entity actually includes and involves vaginal symptoms, vaginal dryness, vaginal burning, irritation, and pain, sexual symptoms, Dr. Thomas touched on that, painful sexual intercourse, decreased orgasms and libido, and then urinary symptoms, painful urination, urgency, frequency, urinary incontinence, and recurrent urinary tract infections. And I'm a firm believer in a picture speaks 1,000 words. And one of the things that I am really committed to is making sure that when you leave my exam room, that you actually understand, that you have a picture in your head, that you actually can relate and connect to what is happening anatomically and physiologically, so that it helps you to be empowered in what are the things that you need to do, how do you need to engage in taking ownership of what your body is doing and being able to have mastery over what your symptoms are and how it is that you will actively partner with us in order to improve your symptoms. Next slide. So here is the part of the urinary tract. This is the uterus, the ovaries, and then the lower urinary tract that involves the vagina, and the urethra and the bladder are not really indicated here or shown here. But These are key elements that I'm going to come back to as you really look at what are the underlying issues that occur with this genitourinary syndrome of menopause as the hormones, especially the estrogen, decline. If you look on the left, this is what premenopausal or normal estrogen levels look like. The vaginal walls are elastic. Vaginal lubrication is present. The vaginal lining is thick and moist. And the other side, which is the side that represents the hormonal decline, one sees that the vaginal elasticity decreases. The vagina becomes drier. The vaginal lining is thin and dry, and the vaginal canal shortens. Next slide. And what does this actually look like from a microscopic level? So on the left, here is the high estrogen environment before menopause. So this is what the vaginal cell looks like. You can see at the very top, that kind of brownish section are the superficial cells. Those are the lining where the lubrication occurs of the vagina. And look at how thick that is, very, very thick and robust. The cells below that form a nice layer, and then underneath are the basal cells. On the right, the low estrogen environment, look at how the thick lining of the cells on the left now become incredibly thin. And similarly, if you look on the right, underlying that thin lining, you can see on the left what is normal. There are a lot of vessels providing good blood supply to the vaginal lining. On the right, things are now atrophic. The vessels have become shrink. They are much more fragile. And as a result, the vaginal lining is thin, it is dry, it is much more easily irritated. And how does this then relate to the four things that I told you about in terms of what are the most common complaints that I see in my practice? So, urinary urgency and frequency. Some coined overactive bladder. All of these changes that are happening in the vaginal lining, in the vaginal canal, are also happening in the bladder and are happening in the level of the urethra. They're all part of the same genitourinary structures. And so what that means is that thinning creates a level of irritability. The nerves become much more closer to the surface, they're much more easily irritated, and so the bladder becomes very spastic. So that overactivity, that gotta go, is a result of bladder spasms that keeps giving you the signal as if you need to use the bathroom when you may not need to. You go frequently, there's only a small amount, or it gives you a signal and you don't have enough time to make it to the bathroom, and so you're leaking on the way to the bathroom. That is because of the thinning, the irritability, the nerves being more exposed, and you have this bladder irritability. Second is recurrent urinary tract infections. Why is this an issue? Well, I always tell my patients, our design leaves me questioning a little bit what happened that the anus and the vagina and the urethra are all on top of each other almost. So you have dirty and clean intermingled. And what that means is that you could never possibly sterilize your vaginal area enough to get rid of the GI bacteria. So you have dirty bacteria living in the vagina, populating that area, and being pushed into the urethra during any type of vaginal manipulation, whether it's intercourse, whether it's a vibrator, whether it's putting in a tampon, that pushes your own bacteria from the GI tract into the urethra. Well, we actually have a layer of protection. It's like a brick wall in the bladder and the urethra that prevents those bacteria from penetrating and getting into the bladder lining. Well, guess what? When that lining thins out, now instead of having a brick wall, you now have a paper wafer. And so the bacteria are able to penetrate that wafer. Now, we're all going to get an infection here and there. When you get one urinary tract infection, bladder infection, it's like those bacteria take a pickaxe and they're picking holes into the lining of that urethra and bladder. And so now what that means is you have these open windows in the lining. So not only is the lining thin and wafer-like, now the bacteria have plugged these holes, poked these holes, and now the bacteria are open season. So many patients will come in and say, I just keep getting one infection after the other after the other. Well, because that first infection created these entry points into the bladder wall. And so as soon as you off that antibiotic, in comes the bacteria again, right through that portal, and it becomes this cycle. And so the other thing that's affected is the ability to heal. Obviously, if the blood supply is not as good, you're not going to have really as kind of robust healing of the bladder lining and the urethral lining. So many people will have the treatment, take the antibiotics, and then they'll come in, but I'm still having symptoms. Well, it's like having a bruise or a cut. It takes a while to heal. So even after the bacteria are removed, there's still the healing that has to happen. That injury to the bladder lining persists and takes some time, so you continue to have those type of symptoms. And similarly, microscopic blood in the urine, I see it on and on. Well, you could imagine if the lining is thin and fragile, it bleeds much more easily. So when you come in to see me and people have gone on to Dr. Google and they've come in with all these catastrophic types of ideas of what this means, 99% of the time, we're not going to find anything that is going to be of concern other than that atrophy. And then urinary incontinence, whether it's urge incontinence or stress incontinence, we talked about the elasticity, the importance of the hormones, especially if you've had children. Think about when you stretch a piece of elastic and you overstretch it, eventually it becomes very saggy. Well, the same thing happens with the pelvic floor. You push out a couple kids and you're happy until 10, 20 years later, and now you're leaking all over the place. But then you add the hormonal changes, and now you really sag. So now you're coughing, you're sneezing, you're walking, you're yelling, and you're losing urine. Next slide. Well, we can do something about it. And the types of things we've talked about, vaginal estrogen, I would say that every woman who is postmenopausal should be on vaginal estrogen. It can change your life. Lubrication, moisturizers, lifestyle changes. We talk a lot more about that educational part in the office, but there are many things that we can adjust that contribute to things like bladder or irritability, overactive bladder medications, PT. Botox shows up again. Botox has a whole bunch of uses, and we use it in the bladder to deal with bladder overactivity. Neuromodulation is a way of managing the control of the nerves. Anti-incontinence procedures that will include things like supports, slings, now urethral bulking agents that involve injections into the urethra that have become much more effective and can be done in the office. So we have lots of things that we can offer you to really help you get your life back. My charge many times to my patients is that if your bladder is dictating your every move, if you know where the bathroom is on every single rest stop, every single store you go into, you chart where you go and when you go based on the access to the bathroom. If your life is dominated by your bladder, then we can do something about it, and it's just nowhere to live. So we can help you with that. Similarly, UTI prevention and prophylaxis. Intimacy is something that's very important in many relationships, and various forms of intimacy. Physical intimacy is one of those. And we don't want you to have your life to be derailed, that quality of your physical interactions with your significant other to be derailed by the fear of urinary tract infections that occur after you have had any type of vaginal manipulation. So the long and short of it is, back to my 3 points. We know what this is. We understand it. We can help you. And you should come see us if you need that help.
All right. So you heard Dr. Williams. Go see her. Get help. All right. Is it now your turn? Dr. Regulin Coyne. All right. So Dr. Regulin Coyne completed her undergraduate studies at the George Washington University, majoring in chemistry and economics with a minor in public health. She went on to earn a master's degree at Johns Hopkins University School of Public Health. Following medical school at Eastern Virginia Medical School, she spent 5 years in general surgical training at UMass Medical Center. In addition, Dr. Regulin Coyne completed a 2-year research fellowship at UMass, focusing on surgical oncology, clinical outcomes research. She has been at Emerson since 2015 and keeps our ORs very busy, having performed more than 2,400 operations at Emerson. Dr. Regulin Coyne is the director of the Emerson Health Comprehensive Breast Health Program and has led Emerson's NAPBC accreditation for breast health for the last 5 years. She has been honored on the Boston Top Docs list for the last 3 years and serves on a number of hospital committees. Outside of the hospital, she is raising 4 children with her husband in Harvard, Massachusetts, where they are involved with soccer, lacrosse, and school programs. Now, Dr. Regulin Coyne.
Hi, everyone. Thank you for coming. What a great event. And, I'm learning so much about things and might need to talk to some of the docs as well for children. So I got a bit of a serious topic. So I'll try to cover as much as I can in the time and try to keep it to the point. So if there's one slide to pay attention, this is it. So, if anybody has anything ever developed, I want to see you in my office the earliest you can possibly be seen, because that gives us more options, we can get away with less, we can take care of it easier. So the things to remember, good breast exam. So first, you really kind of stand like that, hips in front of the mirror, hips on your hands on your hips. And you make sure there's no masses, no skin dimpling, no retraction, nothing kind of irregular, and there's no asymmetry. And you look for nipple changes and bloody discharge as well is always concerning. Then you raise your arms back and forth, make sure everything is moving symmetrically and there's really no changes. And then you lie down and check one side at a time. And you don't have to do it every day. Once a month, set reminder on your phone. If you're very regular period-wise, probably not perimenopausal, then I'd say iPhone reminders work fantastic. So once a month so that you kind of are consistent and stay on top of that. So if something is found, what do you do next? The next step is, there might be some imaging involved. And, briefly, there are 3 things we usually do. Mammograms, and there are 3 types. Screening is kind of simple to view. Diagnostic, we zoom in, take extra pictures, squish more uncomfortably, but for good reason. And, 3D imaging is, mammogram that allows us a little more resolution because, it gives us the 3rd dimension. MRI, ultrasound, is looking at ultrasound waves that, depending how they bounce off the area, allows us to determine if it's more or less concerning. And MRI, of course, is using magnetic fields instead of X-rays to give us, again, a little more information. And, none of them are perfect, but in combination in the right setting, they really give us good information. Note, one thing that we really do not recommend is thermography. Occasionally, I do see patients in my office who had that done, and based on the kind of national guidelines, that is really not the best way to do the screening. So, what are the guidelines? There's a number of organizations, and each one has a little different set of guidelines. So I try to combine them and give my personal opinion on things. So I really think it needs to start at 40, and that's based on kind of the most current guidelines. Once a year is a good way to start. There is discussion for women 55 and older that if they have low risk and they have no family history and really never had any mammograms flagged, sometimes that can be spaced out a little bit. However, again, in my experience, there's such a drastic change that can happen in a urine mammogram that I would stay in once-a-year mammogram and really would not phase out from that. And the reason I put a couple of pictures there of a blueberry and a raspberry. So, I want you to understand that clinical exam is very important and knowing your breast is very important, but mammogram is just a lot more sensitive. So the way I kind of describe it, if you think of a Maine blueberry, this is what mammogram can pick up, something 4 or 5 millimeters, sometimes even smaller. And, but for us to feel it, or to find it on self-exam, it really needs to get to the size of a raspberry, maybe 2, and that's even if you have a smaller breast. If it's a larger breast and the area is deeper, you kind of get a little behind schedule on that. So it's really important to get those mammograms done. So let's get your mammogram. So how do you determine, who needs a imaging or who needs closer follow-up? So that's, what we call a high-risk screening. So that's in addition to mammogram, we get MRI 6 months apart, we get closer exams, a little more attention given. And there's a number of risk score calculators that we can use based on personal factors, atypical cells, that allows us to determine should we watch somebody a little closer to make sure that if something were to happen, we catch it as early as we can. And sometimes it's related to a known genetic mutation and prior radiation therapy, certain syndromes, DES exposure, prolonged hormonal therapy. I think every case needs to be discussed case by case basis, and there's actually risk scores to determine kind of pros and cons of hormonal therapy in personal setting to determine, is it safe to do it in some cases and is it not? And I certainly saw patients for discussion where, they have family history, but they also have miserable day-to-day symptoms, and then we have to decide, well, is this percentage increase in lifetime risk is worth 100% improvement in your symptoms? So I think that's, again, case-by-case discussion, and I don't think there's ever black and white in medicine. It's really more complicated than that. So what does genetics have to do with everything? So again, certain risk factors and certain genes can put you at risk, and you can inherit it from, mom and dad, 50% chance you can get a gene from each one of them. And, the ones that predispose you mostly for breast cancer is BRCA1 and 2. But now we're actually expanding that list. So, the most recent panel is actually looking at 13 genes that can put you at risk for breast cancer. So know your family history. When you come see your doctor, tell us your family history, because that allows to really determine what's the best screening schedule for you. And, genetics is not everything. Just because somebody has a gene, it's not 100% chance that you get something. That's a risk factor, and there's still things we can do to reduce your chances. Good eating, making sure you're exercising, staying healthy, avoiding alcohol, smoking, things like that. And again, majority of the patients I see have random breast cancers. About 90-95% of cancers I see have no family history at all. So it's really more important to staying on top of it. And and if you have more questions, certainly come see us. We have a special program to look at patients who have at-risk personal factors as well as genetic factors that we can really determine what's the right plan and make it happen. So if somebody had imaging, had an exam, and they're worried, and now they need a biopsy, now what? So then you get to see me or one of the other surgeons at this hospital who does breast care. And we do an exam, we figure out the plan, make sure that we figure out the right imaging, the right way to do things. And one thing I always want to mention that I'm sure that's that room in my office is probably the most terrifying room, and that wait is really long till I come into the room. And it's very important. Try to stay away from internet, because the patterns are designed to make you stressed, and it's good studies showing that when you're more worried, you spend more time looking. and you look at more ads. And Google does that to you, so are all the other modalities of social media. So it's important to kind of get good information from good sources, but kind of try to stay cool. And sometimes biopsies, of course, come back positive, and then we make a plan, but also it's important to remember that only 20% of the biopsies actually come back positive. So just because somebody needs a biopsy doesn't mean that it's automatically something is going to be there. So what happens afterwards? So that's when we really, if the biopsy comes back positive and somebody has a new cancer diagnosis, that's really when we start getting the team together and figuring out the best plan. And that involves meeting a surgeon. I'm seeing some great medical oncologists, Dr. Narasamy, I think Dr. Fu, I didn't see today, who, are part of the team, the radiation oncologist. And we also all sit down and take a pause and discuss the case as a team. And you can see, a picture on the top that has lots of little boxes and the slides, and we review everything from imaging to radiology, to pretty much everything specific to this case to figure out what's the best plan to do things, what order makes the most sense, and what's the best next step. And you kind of meet part of the team along the way, and you meet our lovely nurse navigator, Kim. I don't know if she can wave. Here we go. And she's there throughout the whole process to have a good, support and great thoughts and some advice along the way. So we're lucky to have her. And of course, we do some other workup studies as needed along the way. And then generally the first step is, we kind of figure out that custom plan, and then the first step almost always is surgery. And there's different options. Again, there's no simple solution for everybody. Sometimes it's just a small surgery and checking the lymph nodes, and we can now have lots of opportunities to use smaller incisions, hidden scars techniques where, once you're done with surgery, you actually heal well, and, breast cancer is not the first thing you think about when you step out of the shower, a year later. And, sometimes it's even more advanced options like breast reduction lumpectomy, where cancer is removed, but we're able to do it through incisions and patterns where, it actually looks like a breast reduction. And sometimes, there's more complicated cases where we have to consider mastectomy. And sometimes you can do implant reconstruction. There's other options that Dr. Inglaser will talk a little bit about later. So what else happens? There's usually after surgery, we talk about a special pill treatment if the hormone receptors are part of the cancer. And sometimes there's chemotherapy and radiation. And then, that kind of all takes 6 months, sometimes a little longer. And we take a pause and figure out, now what? How can we put all this together and continue on to thrive and survive? And, sometimes we do have programs available that can help you along the way that we're able to incorporate here at Emerson and in the community as well. We were working with our Health and Wellness Steinberg Center and developed a nice Surviving and Thriving program where, it directs you to great classes from, mindfulness to osteoporosis prevention, to other things that are not specific for breast cancer, but really allows you to be part of the community, but really get the right resources. And again, it's really a team approach. So you're never alone in that journey. And there's a lot of stuff happens behind the scenes to support you and help you a little bit along the way in that difficult journey. And of course, there's other factors that happen along the way. So, for people who need it, we can establish counseling and set them up with support services from our busy oncology social workers who check in on patients, figure out their needs, as well as, specific counseling for cancer patients. There's also a number of integrative therapies that we incorporate in the treatment from the Health and Wellness Center, from Reiki and yoga, mindfulness training before surgery. and Be Strong program, as well as osteoporosis prevention program, and physical therapy that's in preoperative setting, as well as lymphedema prevention program that we've been working with our physical therapists that also have a table there, so you guys can check them out later. And we also have great funds that were supported and established within the community, and Emerson patients benefit from Jennifer's Gift of Hope Fund and Joe Andruzzi's Foundation, Ellie's Fund, that help anything from giving kind of gift cards for groceries or gas, assistance with mortgage, or sometimes helping with childcare. So there's many ways to get involved. Oops, sorry. So to bring it all together, I think, one, stay on top of it. Do your exams, stay on top of your mammograms, set the reminder once a year that it's the time. Pre-medicate with Tylenol for a couple of doses. I had my mammogram done a year late, as we all forget to do things on time. But Tylenol, 3 doses before you go in is the way to go. So a couple of myth busters, because those things I've heard in my office within last year, and there's many more, but I think this is kind of important to mention. So if you don't have family history, you would not get breast cancer. Not true. 95% of patients in my office don't have genetic predisposition, and even if they're sitting in front of me with a new breast cancer diagnosis. Wearing a bra can cause breast cancer. Not a big fan of bras a lot of times. Patients don't like them, but it does not cause breast cancer. Mammograms cause breast cancer. It's a small dose of radiation. It's about the same amount of radiation as you get flying from Boston to California one way. So I don't think anybody will stop getting on the plane from getting that kind of exposure. So get your mammograms. I think that will save you a lot of radiation later on if somebody does get breast cancer. Using deodorant can cause breast cancer. Really no studies supporting that, but I think used a lot in marketing certain products. It only happens in middle-aged women. Unfortunately, no. I think the youngest patient this year was in mid-20s. Carrying cell phone in your pocket, also no great data to support that. So, don't believe that. So, resources. How do you find more information? If you go to our website, Comprehensive Breast Health Program, there's a lot more information about this and more things that I discussed. There's more information about all the team members that are part of this, because, there's a lot of people involved, and we're very fortunate to have excellent resources in collaboration with Mass General Hospital, so we can have medical oncologists and radiation oncologists on site, following the same protocols as downtown, using the same radiation oncology machines as downtown. You just, skip the 1-hour drive and $40 parking. So it's kind of nice. And, and we were lucky enough to really show comprehensive services that meet all the criteria for comprehensive breast health program. And, we keep track of our metrics and quality outcomes, and really aim to provide the best care we can for our patients locally. So that's it. And this is our lovely team from earlier this year. And thank you for your time.
Thank you. How many people can say that they've learned at least one new thing tonight? Excellent, excellent. So, last but certainly not least, we have Dr. Joanna Inglazier. She's a plastic and reconstructive surgeon employed at Emerson Health Plastic Surgery. She attended Boston University School of Medicine and completed her general surgery training at Boston Medical Center, which included 2 dedicated research years at Massachusetts General Hospital, studying peripheral nerve regeneration. She then went on to complete her plastic surgery fellowship at the University of Pittsburgh before embarking on a solo practice journey at Emerson Hospital. She collaborates frequently with other surgeons in the hospital, and her practice consists of both cosmetics and reconstruction, ranging from facial aesthetics, Botox, fillers, breast and body contouring, to breast cancer reconstruction, skin cancer reconstruction, and transgender care. She also serves as the medical director of education at Emerson Hospital and is a medical director of the inpatient surgical PA service. Please welcome Dr. Inglazier.
Okay, I have a very tough act to follow, acts, so hopefully you won't disappoint. This is the part where you are happy you chose to spend your evening here and not at home watching The Golden Bachelor or White Lotus. So hopefully there's some entertainment here. All right, so since I am turning 40 next year, I will be seeing you, and all of you. So, all right, perfect. All right, so let me see if I can figure this out. All right, so the whole point is self-care, right? So we're going to want to debunk what everyone thinks of plastic surgery so that you know that it's pretty normal. Your neighbor, your best friend, your mom, your sister probably has gotten something, and don't be embarrassed. It should be an open conversation, just like everything else we all talked about. So we're going to talk about myths and kind of debunk them. So myth number one, plastic surgery is boobs and butts, right? It's like Hollywood, everyone looks at social media, but I just want to let you know that yes, we do boobs and butts, but we do a lot more than that. So again, we break up plastic surgery. There's cosmetics, which is everything you guys hear about and read about in Hollywood and social media. And then there's a whole reconstructive part. So that's where we take care of burn patients. We take care of cleft lip patients, congenital deformities. We do a whole bunch of cancer reconstructions and really just try to restore form and function. So plastic surgery is called plastics, not because you look like a plastic Barbie doll, but it's because it comes from the Greek word plastikos, which means to form or mold. So we're restoring form and function. If that means a lifted boob to you because of kids and all that good stuff that we've all been through, fine. If that means getting rid of some wrinkles, great. But if that means that you've been burned or you've lost a breast to cancer, our whole goal is to get that back to you. So it's cosmetic and reconstructive. We treat everyone. We treat babies. We treat pediatrics, adults, geriatrics, and then we treat all genders, including, as Michelle had mentioned, Dr. Delancourt had mentioned, we do some transgender care as well. We work in a variety of settings. It's not just, Hollywood. We work in the office, in the hospital, in the ER, surgery centers, everywhere. And we often overlap and collaborate with other specialties. So here's just a list of some things that I do right here at Emerson. From facial aesthetics, Botox filler. Dr. Thomas will inject each other, I think. We found injectors. Breast aesthetics, obviously, whether or not you're lifting, we can make them bigger, we can make them smaller, we can rise them up. People usually don't ask to put them down. We can do body contouring, so the infamous mommy makeover. That just means we're doing something to make your boobs and your belly look a little bit nicer pre-child, if that's applicable to you. We can do liposuction. We use fat these days to sculpt and mold. It's pretty awesome. And then we do tiny things like scar, keloid injections, earlobe repairs, ear piercings. We do skincare. We do non-surgical rejuvenation. On the reconstruction side, these are all the things we do at Emerson. So we do breast cancer reconstruction, skin cancer reconstruction, transgender care, massive weight loss, body contouring patients for all of Dr. Doy and Dr. Loud's patients. We do gynecomastia correction. We do wound care. We sew up lacerations in the ER. So plastic surgeons are pretty versatile. It's not just about what you see on TV or in social media. So myth number two, Botox parties are a good idea. So they're not, but they can be really fun. They are if you're getting injected by someone who knows what they're doing. So it doesn't have to be a board-certified plastic surgeon. It can just be a nurse injector, a master esthetician, someone who's actually trained, not just taken a weekend course and wants to make some extra bucks. So the point of that is 100%. Go do that if it's fun and it's legit, but you don't want to end up with the droopy eye that everyone sees, and you don't want to end up with a bad complication. So the point here is you want to go to someone who knows what they're doing. When you're talking about surgeries, it's really important to make sure you're actually seeing a plastic surgeon and not a cosmetic surgeon. Often it's confusing what a cosmetic surgeon really is or what they call themselves. So it doesn't necessarily mean they're a plastic surgeon. Med spas are awesome for so many reasons. I mean, I go to get my facials and my massages at med spas, but I don't go there for like a facelift because it's just not the right setting. You want to be in a hospital maybe, or like a surgery center. And if you ever want to look up what a board certified, if the person you're seeing is actually a board certified plastic surgeon, you can look it up online. There's a whole registry. In either case, plastic surgery centers, same thing, not always equivalent to an actual board certified plastic surgeon. So the point is, you care about yourself, you're doing this for you, make sure you go to someone who knows what they're doing. That being said, my friends on Bosch are like legit board certified surgeons, and that's why they're so good and so entertaining. So that's that. All right, myth number 3, plastic surgeons work in solo private practice. So I do have a solo practice, but I'm employed. And the truth is that we collaborate with a lot of people and a lot of different specialties. So at Emerson alone, these are all the specialties I've at least worked with, whether not necessarily surgically, but definitely collaborated with or consulted with. General surgeons, the breast surgeons, orthopedics, urologists, neurosurgery and spine surgeons, bariatrics, the internists, the intensivists, when we're talking about wound cares, people who have decubitus ulcers, things like that. I work with a dermatologist for all skin cancer reconstructions. We work with ophthalmologists for oculoplastic things. ENT, OMFS, we all kind of overlap, but we all ultimately just sort of collaborate, and that's why I love plastics. We're kind of always involved in everyone, so just keep that one in mind. Myth number 4, plastic surgery doesn't look natural. So here, hopefully you don't feel too triggered, but I am going to show you pictures, and all of my lovely patients have consented to have their photos shown. So hopefully it's none of you, but all right. All right, so no. So the point is, it can look natural if that's what you tell your plastic surgeon and that's what your goals are. So long gone are the days where you go into the office and you're like, I want a breast augmentation, and the surgeon says, perfect, and you wake up and they're like automatically double Ds, and you're like, I'm not sure that's exactly what I wanted. Nowadays, you set your goals, or whoever you're seeing for plastic surgery should defer to you. We do that for breast cancer reconstruction. It's the same aesthetic goals that we apply even for something like breast cancer. So one is you should tell your plastic surgeon what you want, what you're looking for. Show them pictures, especially with social media. Say, I want Botox because I look tired, but I really don't want to be completely frozen like so-and-so in Hollywood, right? So you should be able to verbalize that and communicate that with your surgeon, and more importantly, they should listen to you and actually do what you want. So ball is in your court. Everybody's choices are unique, and if you convey them, your surgeon should actually follow what you say, or else it's a red flag. All right, so Botox helps with wrinkles. It is an injection, it's not permanent, but everyone uses it, and it is pretty awesome. So here's an example of the 11s, which really, if you never knew what an 11 was, it's the frown lines in between your eyes that look like 11s. Sometimes patients come in, they're like, the 9s? I'm like, no, I think the 11s is what you're talking about. But they look like 11s. So Botox, if you inject it into the facial muscles, they relax them. That's what they do. It's a neurotoxin. And then if you relax the muscles that are causing wrinkles, you'll soften the wrinkles. That's injection to the forehead. Again, doesn't have to look super frozen or super crazy or super, curved up. As long as you tell your plastic surgeon, I don't want to be too frozen like Elsa. I just want to kind of be a little bit frozen. Then you'll be fine. Filler is another thing that people worry about, like the Kardashian duck lip look. But if you want a little bit of volume augmentation, which is what happens when you age, you don't have to get duck lips. You can just look something a little bit more full, but still natural. We are aiming for subtleness. So this gentleman wanted a slight chin augmentation to make them look more manly, and we put some filler in the chin area, and it's very subtle, but I think it makes a big difference. So you can be natural. Moving on to the face, upper eyelids are very popular. Most of the time, is there a pointer here? It's this extra heavy hooded skin on the sides, and there's less room to put your makeup. You don't look as bright, you look a little bit more tired, and then we just cut off a little skin. You look a lot brighter, and it's very subtle. It's not like she looks different, but she certainly looks better. Breast augmentation, very popular. Can happen after, or you can get involution after breastfeeding sometimes, especially if you aren't large to begin with. We usually do that with breasts, and again, we're not making them double Ds. We just want something that looks natural, that fits your proportion and that you want. We also make breasts smaller, like I said, so breast reductions are very popular. It's often women who are very heavy. They cause a lot of back pain. There's some rashes underneath, and so when we do a breast reduction, you get a lift in the process, and women are walking in without bras, and they're just like, look at my boobs, they're awesome. And so these women, like everyone we treat, whether or not it's cosmetic or reconstruction, quality of life is just through the roof, and that's why I love doing this. And again, it's all about you. So we treat men too. So gynecomastia is the opposite, where they have a little breast bud, and we basically do liposuction, we do subtle techniques to hide scars, and again, not making you look like you have pec implants, but we're just trying to make this person feel less self-conscious about the fact that they have a little breast tissue prominent here. Breast reconstruction, again, we're not going to talk too much about this, but I collaborate with all the breast surgeons at the hospital. Whether or not it's a lumpectomy, we could do a reduction or a lift at the same time, or a mastectomy that requires me to create something from nothing. So I can use fat, you can use an implant, you can use your own tissue, and then you can do contralateral procedures, and then you can do nipple reconstruction. So we can kind of do our best to give you something that you don't feel like you're missing a part of you because you had no control over that part. Plastic surgery gives you a little bit more control. All right, so tummy tucks, mommy makeovers, very popular, and I've actually done a lot. I think my goal is to operate with everyone at some point before I retire, but I'm getting there, like Laura, Lisa, I think I've done joint cases with everyone here. So it's very common that a woman will need or want a tummy tuck because their muscles have separated because of pregnancy or weight or et cetera, and they just want their core to be stronger, so we send them to PT. Not the best, pelvic PT, still not the best, and you really just need surgery to tighten those muscles back up. Oftentimes, these women will also have hernias or in the belly button, umbilical hernias, and so we just kind of do a 2-for-1, and they really like that. But the whole goal is to tighten your belly, do a little lipo, take a little bit of skin off. You get a very nice contour, but you're trading it for scars. So despite what you think, plastic surgery is maximal scars. We can't do contouring through a laparoscopic incision. We're just very good at hiding them. So it's very low. And so when she wears underwear, you can't see it. But it's the truth about plastics. Here's another example with her little hernia. Very cute, but she don't want it. So she looks really great. Like her contouring's awesome, but big scar. All right, I think this might be the last one. I can't afford plastic surgery. So obviously you have to kind of budget for it, even for Botox, which is not permanent. But I always say if you're spending money on a nice dinner, on travel, facial, hair, nails, you could probably budget for a little bit of Botox too. So a lot of places will have financing options. You just have to ask. And then, again, insurance may cover some procedures. You just have to ask. Okay, a couple more. Fat is bad, but fat is actually pretty good because what we do with fat is we take it away from where you don't want it, and sometimes we throw it away, and sometimes we put it back, but where you want it. So if, we could do a 2-for-1 where we contour the belly, but rather than throwing it away, we can put a little bit into the breast, into the face, areas where you've lost volume. It has a lot of stem cells, and from a research standpoint, they know now that it can actually reverse effects of radiation. So a lot of my patients who've had radiation after breast cancer and they've got a little divot and a scar contracture, we just put fat in there and it really helps with volume and contour, makes a big difference. People are injecting it around neuromas for nerve pain and in the feet for diabetic feet. I think there's evidence that if you inject fat in there, you thicken up that sole of the foot, it actually improves pain. So there's a lot of good things about fat. It's not all bad. And the last myth is implants are bad. We're not going to go into this too much, but you can talk to me after and you can feel them. They're on my table. But this is a silicone implant. The truth is that they were really bad in the 80s and the 90s. They were off the market for about 7 years, but now they're back on the market, meaning they must have gone through a lot of regulations and changes since then, and they're safe again. So they're better regulated. There's better safety protocols. There's more education we have to give to our patients before you decide to have an implant. And they're actually pretty good devices. So if you're interested, go feel one, and you can always ask. So in summary, biggest tips is if you're curious, just make a consultation. I promise I don't bite. All we're going to do is sit and chat, tell you everything you need to know, and then it's all elective, so you don't have to say yes. If it makes you feel good, do it. You're worth it, right? We all been through a lot. Prepare to budget because it's not free, unfortunately. But if and when you are ready to do something, whether or not it's injection or surgery, just make sure that it makes financial, social, medical sense to you. So please don't do it when you've just had surgery or you're diagnosed with breast cancer. Don't come in being like, okay, what can I do for my eyes? Which does happen sometimes. I said, let's work on that first. You do need the proper support networks in place. So I screen all of my patients if they're going to have a big surgery to make sure they don't live alone and or they have a plan for work, their exercise plan, and someone to help them out afterwards. So because everything I do is elective, these things are actually more important than most other surgeries. And then find someone who knows what they're doing. That's it. Oh, that's it. Thank you. You can follow us. And I want to thank everyone for all your awesome bra donations. I'm like floored by how many donations there are. So they're going to go to a good cause. October was Breast Cancer Month. November is now Botox Month. So.
All right, let's give our panelists another round of applause. That was amazing. So tonight, we've delved into the diverse and vital aspects of women's health, exploring topics that impact the lives of all of us women. As we stand here, I want us to, at the crossroads of knowledge and action, I'd like us to pivot our focus just a little bit for a moment to primary care. So although I am in urgent care right now, I am primary care trained, and I want you to remember that primary care is important. And if you think of it as a compass that guides our journey through the vast landscapes of women's health, it's often the first point of contact, the guardian of preventive care, and a gateway of wellness. You can think of primary care as the foundation upon which we build a healthier future for all of us as women. So it is where we have early detection, and we can build wellness strategies, and where empowerment really begins. So by staying on top of regular health screenings, including mental health screenings with your primary care provider, you are taking care of your body. You're nurturing the incredible woman that you are. So there is an infographic in the back as far as reminders of different screenings that you are to do at different ages, so please be sure to take one of those. So we have now reached the moment where we want to hear from you. This is your opportunity to ask questions, share insights, and explore the topics that were covered here by our esteemed physicians. So I'll have them all come to the center here. And so we have mics going around, and I don't see a clock, so I hope someone can tell me when it's time. But please, the floor is open. Who has a question?
I can kick it off. I have the questions that some of you submitted through QR codes. So the first one is there a correlation between menopause and muscle loss? And if so, what can you do for it besides exercise?
There we go. I think this is on. So yes, there's a decrease in muscle loss everywhere. I mean, we see it in our face, the collagen, the elastin, the muscle mass just in general. Besides like lightweight strength training, if it's something like we can do physical therapy, a lot more joint aches and pains happen, and it's not something that hormone replacement can build up muscle. It is just strength training. And if there's a problem like the diastasis, like Dr. Englazer said, there could be surgery. That's really it. Yeah. Vitamins. Protein, good diet. Yeah.
Collagen.
Supplements,
There's actually a really interesting study done a while back, and they looked at the healthy muscle and looking at people who exercised and compared their muscle biopsies. I don't know who signed up because muscle biopsies are so painful. Muscle biopsies and correlated to their x-rays to see what their progression with osteoporosis is. And it was amazing because they had patients like from age 30 to nearly 90s. And really the muscle, even in older patients, the people who exercised and kept the muscles strong, there's really no way to tell the age of the muscle, but it truly correlated to how the bones looked on the imaging. So it's always, it would be great to have a pill for everything, but, even it doesn't have to be throwing kettlebells around. Even though if you like that, that's fantastic. It can be yoga, it can be Pilates, it can be pickleball. It can be so many ways as long as you're doing it. Moderate exercise, 30 minutes, 3 times a week. And, make it social, go with your friends, make it, join a group. There's many ways to do this, but it's so important, and it's really sets you up to be healthy and have good balance later on, and it's just really cascades, has so many positive results from it.
One note on protein, it should be, and someone, Dr. Doyen could correct me, 1 gram per ideal body weight, right, per day, is that goal? 0.8. 60 to 80 grams a day, shoot for that. Most women don't do enough, including myself, so I do supplement with collagen because it's a decent form of protein that maybe not evidence-based has other effects on hair, collagen, joints. Not super good evidence behind that, but I like it more than protein shakes and protein bars because there's a lot of additives and aspartame and all that kind of stuff in that. So that would be one option that you could use to help you get to that 60 to 80.
I can go to the next embarrassing question. Can we talk about poop? Frequency, healthy poops, unhealthy poops, what to do if you don't feel like things are working properly?
General surgeon.
I'll take this one. So I usually don't see much of that in my practice. I see that when I'm on call through emergency room. So I would say healthy diet, including high fiber to prevent constipation, to have healthy GI tract, prevent diverticulitis that is associated with increased risk of colon cancer. The Western diet, kind of low in fiber is sometimes a bit of a culprit. And it's interesting because people move from other countries from Asian countries and move to the US, and the risks and their colons start looking
like the U.S. colons within a few years of moving because, we adapt to the local lifestyle. So 25 grams of fiber, which is not easy to get to. So what I would say is keep a journal for a couple days and actually be honest with yourself how much fiber is in your diet. And, and then start swapping things. So white bread versus whole grain bread, now you can get like 5 grams of fiber per slice. So you have a sandwich, you're like nearly halfway there. 8 cups of water a day, certainly might not help with urgency and frequency, but it's actually good for the GI tract. So, I think everybody's a little different. You have to know your body. But I think, if you have questions, we have, a great female colorectal surgeon, Dr. Columbus, who, for some things like incontinence and, other things that might be a great resource for. There's some pelvic PT that also might be beneficial, and we have a great gastroenterology team who will see you and really can go through specific issues.
And if it's a childbirth injury, so you're incontinent sometimes, or you start to notice prolapse and you actually have to push inside the vagina to have a bowel movement, that from prolapse from having children, there are urogynecologists, but also Dr. Columbus probably handles some incontinence and childbirth injuries. But pelvic floor PT certainly can help with that. But a urogynecologist also can help with the pelvic floor posteriorly and fix any sphincter issues as well. So it's variable, but yes, on the fiber, and it's hard to get 25 grams. It really is.
Thank you all. So I have a question about estrogen, because we hear so much about that lack of estrogen as being the culprit for a lot of issues, and I feel the bladder issue I feel seen after that. But what if you have enough estrogen? Are there other hormones during perimenopause and menopause at play that can cause symptoms, or is estrogen really the culprit? Or are there other issues potentially, other hormones as well?
So progesterone a little bit. I mean, they all drop in perimenopause and menopause, estrogen being the one that I think we feel the most effects of. And certainly with hyposexual disorder and libido, it's the testosterone drop. So we don't have as much as men, but certainly the drop in that. So there's some alternative medicines, some bioidentical pellets. I'm exploring testosterone drops and cream soon to help with libido, but we only need a very small amount. I just went to a talk on sexual health, and so it's something that is not FDA approved here in the US, but in Australia and in some European countries, there's testosterone treatment. It's just not readily available here. So certainly the estrogen is a big component for the hot flashes and a lot of the mood changes, the joint pains, the night sweats. But yes, all of our other hormones tend to decrease as well.
Oh boy. I'll come over. Let me ask another question while I get over to you. I pee when I sprint during my workouts. I go right before I work out. What can I do to better control my situation?
That is my question. Like, I go right before I work out. And then, yeah, and if anybody gets orange theory, they're all out. It's all. And if I'm dancing and I jump up and down, so help me.
Yes, well, that is definitely a little bit of a challenge. Certainly, one of the things that I tell patients is that our kidneys are like a faucet that are constantly on. So that many times patients will say, I pee and I jump and I leak. Where's the urine coming from? And it's because you're constantly making urine. So really and truly, if what you describe, which is stress urinary incontinence, which is the support for the urethra, has been affected, Then for mild stress incontinence, usually pelvic floor physical therapy can be helpful. Beyond that, it really does require a procedure of some sort. We have a very new bulking agent that is quite effective and lasts a long time. So we're finding now that whereas patients who would automatically go to having a sling, which is a little bit more of an involved and invasive procedure, now you can have a little injection, a little bulking, same way you bulk the face, etc. We're bulking the urethra. That can be done in the office. And it works pretty well. So we have very, kind of less invasive procedures that will help and that will literally have no downtime. You have it done today and you can be back working out tomorrow. So I would highly, suggest if you're limited because of, that type of stress incontinence, those are your options. You're welcome.
I guess I'm impatient. So I'm curious about IUDs and specifically Mirena, which has a hormone in it. If that increases the rate at which the vaginal lining thins or if it decreases the rate.
It shouldn't have any effect. So it's local progesterone inside the uterus. A Mirena is an IUD, which is a little T-shaped device that has a couple different uses. One is birth control. It's good for 8 years, so it's a long-term form. It also has a small amount of progesterone that has very little systemic effect, so it's not like you're taking oral progesterone that thins the lining of the uterus. And so then your periods are a lot lighter. Most of my patients don't have a period. So we use it a lot for very heavy periods that tend to happen in our 40s, and even later 30s, even after child birth, our periods are terrible. You might find your PMS worsens, all normal. But I use the Mirena a lot for heavy, heavy periods. And so what that does is thins the lining of the uterus. Shouldn't have any effect on the vagina. It has no effect on when you go through menopause. It's really just acting locally in the uterus. Sometimes my patients will come to me and say it's making I have more cystic acne, hair loss, and it's hard to tease out, is that a little bit of the progesterone systemic from the Mirena, or is it other factors going on in a woman's life versus where they are in their decades of life, 30s, 40s, 50s. So it has a lot of really beneficial effects.
I can just project. Can you guys hear me okay? Yeah. So a question about endometriosis, and then is there any research about someone who has endometriosis and the experience of perimenopause or menopause? Is it basically the same?
It's basically the same, and hopefully symptoms, depending on where you are in your journey of endometriosis and what treatments you've used, hopefully it gets better because you'll have less periods, they'll space out, and hopefully the pain factor, especially during the cycle, is better. I don't think there's any research going through an earlier menopause versus later menopause and differing symptoms. Because of the chronicity of endometriosis, you could have more discomfort, more joint aches, pains, depending on where your endometriosis is.
All right. Maybe time for one last quick question.
I don't have a question. I'm a cardiac nurse. I run the cardiac rehab program, and I think this is so exciting because you guys all up there teach a lot of the same things that we teach about preventing heart disease. And about 10 years after menopause, women catch up to men for getting heart disease. So my question is, how can these women in this room that don't have heart disease, how can they predict they're going to get it? And I want to know, one of the things I know is the latest risk factor for heart disease is women that have had preeclampsia. Is that something that you're warning women about, that have had some risk factors that may be able to predict? So first of all, thank you very much because you're teaching a lot of the stuff we teach. Diet, exercise, it helps your skin, helps prevent breast cancer. It also prevents heart disease. So what else can women do to help predict they're going to get a heart problem? Can you share with me something else you might know? That obstetrics, I'm just curious if you have any.
I will have to look up that lecture with the preeclampsia. I'm not sure about that. Sorry, we've gone through epic transition.
Yeah, yeah.
It's time consuming. So I don't know. That's very interesting. I'm going to look at that.
I think we want to know, let's predict like which women are going to go on and get our problem. And I think that is another, anyone who's had preeclampsia might actually have it.
Very interesting. I want to look at that.
I can tell you that.
I also
Dr.
have
Bute,
this,
my medical director is right here.
So yes, preeclampsia definitely is. It's
Yeah.
part of the cardiac risk factor history that we have.
Yeah.
It predisposes to high blood pressure, cardiomyopathy, and eventually atherosclerosis.
Thank you. Thank you, thank you. All right. So I want to thank all of you for being part of this incredible journey through women's health. Tonight, we've navigated some of the intricate pathways of well-being, and our panel of physician women have illuminated the way. But this isn't the end, it's just the beginning. As we conclude this evening, remember that the torch of knowledge has been passed to each one of you. So let's leave here not just inspired, but invigorated. Carry the wisdom shared tonight with you, share it with your friends, your family, your community, and let's continue to light up the path to better health for all women. As we bid farewell to this stage, remember that the journey to women's health is ongoing, and you are all on an integral part of it. Stay curious, stay informed, and stay empowered. Thank you for joining us on this incredible Women's Health Night. And together, let's create healthier and brighter future for women everywhere. Before we end, I would like to take some time to acknowledge many of the clinicians as well as Emerson Health leaders who are present in the audience here tonight. I'm going to ask you to please stand as I call your name. And I hope I say your names correctly. All right, so the first we have is Dr. Lauren Alberta Zolek in the Department of Dermatology. Right. We have Dr. Bute, Department of Cardiology. Dr. Daniela Caprelis, who couldn't make it. We have Jackie Clancy, Vice President of Strategic Marketing. Okay. We have Dr. Alexandra Columbus, part of Cancer Services, General Surgery and Colorectal Surgery. Who could, here? Okay. We have Dr. Laura Doyen, Surgical Weight Loss. We have Renee Fosberg, Vice President and Chief Information Officer. We have Dr. Deb Green, Department of Emergency Services. We have Dr. Nura Namasamy in Cancer Services. We have Dr. Agnes Verga, Department of Neurology. And of course, we have Christine Schuster, President and CEO of Emerson Health. I hope I did not miss anyone. So please take the time to stay and mingle in the back. There's food. Introduce yourself to the number of clinicians who are here. Again, thank you for enjoying and joining us here tonight. Bye.